This lecture will address the second part of the hematopoietic system. So we're going to talk about how white blood cell, that differential, actually helps us signal pathology. We'll describe some of the pathology of myelogenous and lymphocytic leukemia, some of the overarching concepts. It's important that you be able to differentiate between Hodgkin's and non-Hodgkin's lymphoma, and then also have a sense of the pathophysiology and the pathology of multiple myeloma. When we think about leukocytes or white blood cells, there are two general characteristics. The cells are either agranular or they are granular. So the agranular leukocytes are the sites, the lymphocytes and the monocytes. The granular cells are the phils, the neutrophils, the eosinophils, the basophils. And you can see there that when you look at the white blood cells in general, the vast majority of your white cells are neutrophils. And then lymphocytes being the most common agranular, neutrophils being the most granular types of cells. And the granular versus agranular is the way they look under the microscope. They have small granules in their cytoplasm. When we look at the white blood cell differential and we look at the agranular white blood cells, let's look at some of their physiologic function and what you can expect from them. So the lymphocytes, which is the predominant agranular white blood cell, lymphocytes are there to identify and neutralize foreign objects. This is how lymphocytes are important to help us develop both T as well as B cells. So as a result, then, you will see an elevated level of lymphocytes with an infection as well as inflammation. So you think about inflammatory states. I know you can't get rid of it, can you? You would see those in irritable bowel disease, Crohn's. I keep using Crohn's because it's such a common disease, as well as ulcerative colitis, as well as a vasculitis, which you may see in a number of autoimmune diseases. You would expect then also to see a decrease in the number of lymphocytes with chemo, radiation, steroid therapy, and then the presence of Hodgkin's disease because of that suppression of the precursors. Monocytes, the second type of agranular white blood cell count, these are your phagocytes. The job is primarily to remove debris. You may see this with myelodysplastic syndromes like and when we talk about a myelodysplasia, we're talking about bone marrow producing different kinds of cells or unusual cells. But you may also see this with protozoa as well as rickettsial diseases. Working in the U.S., in the urban U.S., we don't see a lot of protozoan and rickettsial diseases. But if you work in less well-developed countries, you are more likely to see a lot of that. Or if you work in a very rural population, you might see a few more protozoal diseases, especially if they spend a lot of times in creeks or lakes that obviously wouldn't be chlorinated. The granular leukocytes are the neutrophils, the eosinophils, and the basophils. The neutrophils, as we talked about, I think we talked about these before, but remember those are your first responders. And as a result, they predominate in early inflammation. Specifically on neutrophils, look for bacterial responses. So that's what I would be looking for if I saw a lot of neutrophils. I would be looking for a bacterial infection especially. With eosinophils, their job is to engulf parasites as well as regulate mast cell vascular mediators. We would look for those in both parasitic infections and, importantly, that allergic response that we talked about when we talked about immune system dysfunction. Basophils are also seen in allergic responses as well as myeloproliferative disorders. So I would be looking for some basophils if someone had a leukemia. And we talked about bands earlier, and bands being those immature leukocytes, and are very important when we look at the differential to see how the body is responding to an infection. When you look at white cells overall, the more immature cells that you find in the circulation, you should consider a malignancy. because in malignancy, the bone marrow drops a large number of immature cells into the circulation. Because remember, when you have the white cells, you start with a myoblast, which then makes a myelocyte. That then develops into a myelocyte. The myelocyte becomes the band, and the band then matures. Let's talk then about some of the disorders. Let's start with leukemias. Although leukemias are actually more common in adults than they are in kids, leukemia is one of the most common childhood cancers, especially acute lymphocytic leukemia. What happens in a leukemia is you have uncontrolled proliferation of abnormal cancerous lymphocytes. And hopefully you've already listened to the lecture on the biology of cancer, so you know that these are abnormal cells. And what actually happens in a leukemia is that bone marrow becomes dedicated to producing these abnormal cells and then just can't produce anything normal. And so what you'll also notice in many of the leukemias is not only do you see this abnormal proliferation of the leukemic cells or the cancerous lymphocytes, you also will see then a decrease in the red cells and in the platelets, because remember, the bone marrow has essentially been taken over by these abnormal proliferating lymphocytes. Leukemias can be acute with a very large and high population of cells that are undifferentiated and that are blasts. Remember, blasts are baby cells. Or it can be chronic. Now, in a chronic leukemia, you have differentiated cells without normal function. So there's a big difference then you can see of the characteristic. In acute leukemia, you have a lot of undifferentiated and blast cells. In a chronic leukemia, you have a high population of differentiated cells, but they don't function normally. The broad categories of leukemia include lymphocytic, as well as myelogenous. And then those are each further divided into acute and chronic. So let's look at acute and chronic leukemias, both lymphocytic as well as myelogenous. When you look at an acute leukemia, in both, you're looking for pathology you look for the pathology as bone marrow indicated. So you're looking for blasts. You're looking for undifferentiated cells. Remember, we're talking acute. So with an acute lymphocytic anemia, I'm looking for lymphoblasts as well as B and T cell precursors. In kids, one of the biggest things to consider as the causative factor, for lack of a better phrase, is whether or not there are actually genetic mutations causing the leukemia. In an acute myelogenous leukemia, we're looking for those myeloid precursor cells, again, poorly differentiated, and you'll look for a leukocytosis with a lot of immature cells, those blast cells. With a chronic lymphocytic leukemia and a chronic myelogenous leukemia, these are more common in adults than they are in children. So chronic leukemias you'll see more commonly in adults. In a chronic lymphocytic leukemia, the pathology is that the B cells are failing to mature to plasma cells. So as a result then, get ready to shout at the screen or while you're listening, what type of immunity would be affected? Correct. They would have a decrease in their humoral immunity. And remember, with a decrease in humoral immunity, you are looking for a pattern of ongoing infections. In chronic myelogenous leukemia, this is a myeloproliferative cancer, and you'll see a lot of hematopoietic stem cells in that proliferation. In these chronic leukemias, there's a great deal of interference with the function of the bone marrow. Let me back up. In a chronic leukemia, interference with function of the bone marrow is less than with an acute leukemia. So less impact on function of the bone marrow itself in a chronic leukemia than with an acute leukemia. Lymphomas are also part of the alterations in the hematopoietic system. With a lymphoma, you have the proliferation of malignant lymphocytes in the lymph system. So that's where the lymphoma is occurring. Most of these are due to either genetic mutations and or a viral infection. The two most common are two big buckets, rather, of lymphomas include Hodgkin's lymphoma and then non-Hodgkin's lymphoma. So those are the two biggest classifications. When we look at a Hodgkin's lymphoma, the diagnostic cell that we're looking for is the Reed-Sternberg cell. So basically what this Reed-Sternberg cell is a transformed lymphocyte. And this actually manifests itself initially as a painless enlarged lymph nodes. And these Reed-Sternberg cells, this lymphoma, progresses from one group of lymph nodes to another. Now remember we said that several lymphomas are linked to viral infections. Hodgkin's lymphoma has been linked to the Epstein-Barr virus and has also been linked on two B-cell alterations. In a non-Hodgkin's lymphoma, you have an expansion of the B, the T, and the natural killer cells. The B-cell expansion is the most common, but in this you do not see those characteristic Reed-Sternberg cells. Once again, non-Hodgkin's lymphoma has also been linked to viruses, bacteria, as well as immunosuppression. So one of the most common viruses, again, is that Epstein-Barr virus. We also see this in individuals who are immunosuppressed following an organ transplant. We do very careful non-Hodgkin's lymphoma surveillance in those patients because of their immunosuppression. Now there's another kind of lymphoma that I mentioned because this is an aggressive B-cell lymphoma in kids, and this is Burkitt lymphoma. You're getting tired of me saying it, but once again, you've got a biggie here. Once again associated with the Epstein-Barr virus, just like the other two were. But this Burkitt lymphoma actually affects the jaw and the bones of the face and has a very characteristic visual manifestation. Great pictures in your textbook, and I encourage you to take a look at that if you've never seen a Burkitt lymphoma. The last disorder we'll talk about is multiple myeloma. Multiple myeloma is actually cancer of the plasma cells, and this can be due to gene mutations or gene changes and or inactivated tumor suppressors. Remember in the biology of cancer we talked about tumor suppressor cells. What happens in a multiple myeloma is the B cells have an overproduction of IgG, and a specific IgG. And there's too much antibody produced to structure called light chains. This increased production of IgG occurs within the bone marrow, which then secretes hepatic growth factor as well as a parathyroid peptide and cytokines. This then leads to activation of osteoclasts and resorption of bone, which then causes bone lesions and an elevated calcium level. So when you think about multiple myeloma, the big thing you want to think about are these this antibody that is being produced to these structures called light chains. And the end result of this antibody production to these light chains is the activation of osteoclasts, which then is going to lead to bone lesions and hypercalcemia. Now, we can actually measure this abnormal antibody because this cancer does not have a lot of symptoms associated with it. So when we find it, we can find this M protein in the serum, or more likely, we usually find this as Bench-Jones protein, which is an immune globulin light chain in the urine. The negative effects of multiple myeloma are on the bone primarily, but it also leads to kidney failure and kidney damage in about 50% of the individuals who are affected. What happens with these individuals is that these light chains that we talked about have to be cleared by the kidneys. Because there is such an overwhelming production of these light chains and the antibody that are associated with it, the kidneys are unable to reabsorb these light chains. They precipitate out late in the tubular mechanism and cause damage to the tubular structures. This is making me nuts. Give me a second. I'm so sorry. So when we think about the things we just talked about, we know that the white blood cell differential provides a lot of cues to infectious pathologies. We can differentiate the probability of bacterial versus protozoan. We can differentiate whether these are the lymphocytes, which we're seeing with infection and inflammation, looking at B and T cells, and we can determine whether or not it may be allergic versus a protozoan infection. Leukemias or white blood cell disorders occurs both in acute and chronic, remembering that in an acute leukemia, you have a lot of undifferentiated cells. In a chronic leukemia, you have a lot of differentiated cells, but they don't do their job. Multiple myeloma is detected through identifying abnormal proteins, and those abnormal proteins lead to breakdown and destruction of the bone, and the systemic effects can also cause kidney failure. Let me know if you have any questions, and thank you for your attention.